So 5-ASA, fish oil, budesonide, Cipro, metronidazole, azathioprine, 6-MP, and infliximab. There's some trials in all of them, and with the exception of budesonide, there's some evidence that they may be effective. And I think one thing that is important is that you can see sort of that there's a bit of a hierarchy as we've gone along, that 5-ASA was the first medication that was used as maintenance therapy. And 5-ASA is pretty innocuous, it doesn't cost very much. And when we were using, and people don't think it's very effective, but you might say, well, what the heck? It doesn't cost very much, it's not very toxic, so what the heck, if it helps some patients, maybe we should put them on 5-ASA as maintenance therapy. But you can see as we've come along, now we're talking about Imuran and infliximab, and infliximab particularly is very expensive. So I think that from that standpoint alone, that we can't just sort of take the, well, what the heck approach, that we maybe need to look at this a little bit closely. So to me, that's some of the issues that we need to struggle with is how do we measure effectiveness? Does maintenance therapy alter the natural history of Crohn's disease? Who should be on maintenance therapy, and should we consider patient preferences? So just as a little bit of a disclaimer that I'll say that back in the late 1980s and the 90s that I did do a study on maintenance therapy. So if you think that my remarks are being critical of gastroenterologists, I'm not. I'm sort of in that group that believe in maintenance therapy, but I am going to be critical of sort of all of us, that I think that we need to think about this area just a little bit more closely. So the trials that are assessing maintenance therapy, that generally the most common outcome measure is endoscopic recurrence. We're guilty of that, looking at endoscopic recurrence. Occasionally, clinical recurrence or symptomatic recurrence is also looked at. Generally, trials are quite short. The average is about 6 months in length. There's a systematic review that I looked at of 12 maintenance trial, and the shortest was 12 and the longest was 156 weeks, but the average was about 6 months. And most studies include patients with disease limited to the terminal ileum. And those are the patients that probably aren't sort of what we would really think are the bad actors who maybe need maintenance therapy, but those are the patients that are in the trials. So the first is, how do we measure effectiveness? And we have to recognize that Crohn's disease is a chronic disease which affects young people. So what is the meaningful outcome? To me, looking at endoscopic recurrence and saying that a medication is effective for maintenance therapy after a study which looks at endoscopic recurrence for 6 months, I think that we can't say that. Using a CDAI or clinical recurrence, some people have looked at sort of what they would consider surrogates, that maybe do we change the need for steroid therapy. But in fact, as we've gone down that list, now except for steroids, but infliximab, we're using the big guns for maintenance therapy. So I'm not sure that the need for steroids or reoperation is really a effective, or it's a correct outcome measure. In fact, I would say that maybe now that we do a lot of surgery laparoscopically, that it's much less invasive, and although patients don't want to have reoperations, that that may not be the best. And really what we want to capture, I guess, is do we have good health or good quality of life over 25 or 50 years? And that obviously is not possible, but that really is what we're getting at. And to tell you the truth, I'm actually just pointing out how difficult it is, because the other area that I work in is cancer. And when we talk about adjuvant therapy, or if we talk about chemotherapy, our endpoint is, does the patient live, do they die, or do we prolong life? And it's very difficult in Crohn's disease, to me, to really have a meaningful outcome. But I think that for us to say that we change recurrence and measure it by endoscopic recurrence or for 6 months, that we probably really can't make any conclusions. The next is, again, going back to the length of the trial and stating that it's inadequate, is what we really want to get at is the natural history altered. And there's relatively little to no evidence on that. There's one study from France where they looked at retrospective data, but population-based data, and they found that the proportion of patients requiring surgery with or without treatment with Imuran was approximately 35 to 40%. And they also found that despite the increased use of Imuran, that the proportion of patients having surgery over a 20-year period of time was unchanged. And so they made the conclusion that maybe, even though there's evidence from randomized controlled trials that show that Imuran decreases the risk of recurrence, maybe in the long term that it's not making a difference. On the other hand, we do have to admit that this is uncontrolled and retrospective data. For the biologicals like infliximab, as far as I know, I don't think there's any data to show that the long-term natural history of Crohn's disease is changed. Then the question is, and I think really a fundamental question is really who should receive maintenance therapy, so that we know some patients will not have a recurrence for a long time, others will recur quite early. And unfortunately, as I've pointed out, that I think that to date that we really cannot identify patients who would do well on maintenance therapy. So if we look overall, that about approximately 50% of patients will require reoperation at 10 years and 70% at 20 years. So you can say, well, that's a pretty high rate. On the other hand, if we look at that, the opposite, that 50% of patients will not require reoperation at 10 years and 30% will not require reoperation at 20 years. And even those who do require reoperation may have to be on maintenance therapy for a prolonged period of time, such as years, maybe up to 10 years. And there are, of course, associated side effects and costs. And the last issue, which has been of interest to ours, has been looking at patient preferences, or what do patients think about the issue of maintenance therapy. So as I said, in the early 90s, we did a study where we had given patients 5-ASA postoperatively. And we actually followed them for about 5 to 6 years. And at 3 years, we had shown that the risk of recurrence, clinical recurrence, had decreased from 40% down to 25%, which me, as being a surgeon, thought that was pretty amazing. And I was very keen on patients going on 5-ASA. And I was really disheartened that patients, many patients refused maintenance therapy. They didn't want to go on maintenance therapy. And one of the most common reasons, which was quite interesting, was that they said that they had had surgery so they could discontinue all therapy. They didn't like taking 12 tablets of medication per day. And furthermore, that they wanted to forget about their disease, and taking medication reminded them of it. And so they didn't want to take it. They were also concerned about the cost of taking medication as well. We then went on and we did a study using the standard Gamble technique to assign utilities to the two disease states. And one was taking no 5-ASA, having a recurrence rate of 40%, or taking it and having a risk of recurrence of 25%. And we couldn't find a difference in the immune utilities. But I think that really it's the wrong thing. Standard Gamble